All right, let's talk about antiplatelets. They all work by decreasing the platelet aggregation. So, first thing we have the heparin. So, what does heparin do? Well, heparin irreversibly blocks the COX, which leads to decrease in TXA2 release, thromboxane A2 release. So, irreversibly blocks the cyclooxygenase enzyme. When you block the cyclooxygenase, you can't form thromboxane A2. So there's a decrease in thromboxane A2. Used in acute coronary syndrome, coronary stenting, decrease incidence or recurrence of thrombotic strokes. But the adverse effect is you can cause gastric ulcer because you are irreversibly blocking the COX, so causing gastric ulcers, tinnitus, allergic reaction, renal injury, syndrome if you give this in a child, except in which sort of arthritis we are talking about in child with. Well, if it comes, it's gonna come. It's start from T. Okay, we'll come back if you guys tell me the answer. Let me see if somebody has written that or no. Okay. Okay, let's move on with the other ones now. What do we have? Second thing we can give clopidogrel, prasugrel, and ticagrelor. These block ADP, which is the P2Y12 receptor. So they're not blocking the ADP, but they're blocking the receptor, ADP receptor, which is P2Y12. Right? That leads to a decrease in ADP induced expression of GP2B3A. GP2B3As. Clinical use, same as aspirin, and dual antiplatelet therapy. Same as aspirin, can be given a dual antiplatelet therapy. Adverse effect is bleeding. And coming back to the topic, thank you for mentioning it. It's the Kawasaki that you can give, not I was thinking about like Takayasu, but I know that it's something, right? Kawasaki. Look at the brain. Wow, it. I mean, you know things, and it's just out. Amazing capabilities. Kawasaki disease. So, if you were to give aspirin in a child, it's going to cause Reye syndrome. What is that Reye syndrome? You have that. You're inhibiting the beta oxidation, causing hepatocytes to have fat, right? So because you have inhibited the beta oxidation of the fats. But in children, you can. There's only one condition you can give aspirin, which is the Kawasaki disease. And thank you for mentioning that. Moving on, as we said, clopidogrel inhibits the blocks the ADP. Remember, receptor, not the ADP itself, but the receptor. When the receptor is blocked, no matter how much ADP is coming, it's not. It can't work because you don't have a receptor. So decrease in ADP-induced expression of GP2B3As. It's a dual antiplatelet therapy. Can be given as dual antiplatelet therapy. Can cause bleeding. Coming to the next thing, which is the eptifibatide. Eptifibatide and tirofiban. they now block that GP2B3. Actually, if we could draw them, that would have been very good. So let's just draw this. We have the platelet. Platelet releases thromboxane A2, TXA2, by enzyme COX. Platelet releases ADP, which works on its receptor, which is ADP receptor, and that causes the expression of GP2B3As. Okay. Let's now say, coming to the blue pen, aspirin, you inhibit the COX by aspirin. Second, clopidogrel, prasugrel, ticagrelor, you have blocked this receptor. So this can go, now GP2B can go out. And third thing, you have the eptifibatide and tirofiban. You're directly blocking the GP2B3As on activated platelets. Fourth, you have the cilostazol and dipyridamole. You're blocking phosphodiesterases, which due to decrease in cyclic AMP hydrolysis and increasing cyclic AMP in platelets. That leads to intermittent claudication. If you have intermittent claudication, you can use this. Stroke prevention, cardiac stress testing, prevention of the coronary stent, restenosis, adverse effect, nausea, headache, facial flushing, hypertension, abdominal pain. And that's all for the antiplatelets.